Hi, I'm Julia Raifman. I'm an assistant professor at the Boston University School of Public Health in the Department of Health, Law, Policy, and Management, and I'll be presenting today on our work funded by the BU CTSI. Back in March 2020, we started to compile the COVID-19 U.S. state policy database to inform COVID-19 prevention policies and policies to prevent economic hardship. Thanks to the investment of CTSI, we were able to support a large team of student volunteers and staff and to compile more than 200 policy variables that have helped inform the response to the pandemic and that we hope will continue to learn from over the coming years. The premise of our work was that COVID brings joint health and economic disasters, and in a context of structural racism and inequities, disasters make disparities worse. That policy actions during disasters can reduce or exacerbate disparities, and federal leadership is key, as is evidence to inform federal leadership and policies. This is true for COVID prevention policies, for vaccine priorities and delivery, and for economic support policies like stimulus payments and expanded unemployment insurance. Finally, disasters can be an opportunity to change structural inequities or inform them in the future, such as learning about how we can reform the unemployment insurance system, minimum wage, and paid sick leave to better support people in all times. Prior to the COVID-19 pandemic, in 2019, there were already large racial and ethnic disparities in wealth that had been shaped by historical and modern day policies. So in 2019, non-Hispanic white households had about 8 times the wealth of non-Hispanic Black households, about 6 times the wealth of Hispanic, Latino, Latina, and Latinx households. And what this did is shape vulnerability to economic hardship as well as to health risks during the pandemic. We have seen time and time again that disasters exacerbate disparities in this highly inequitable context. So that was true with the Great Recession, when it took much longer for populations affected by structural racism and structural inequities to recover from the Great Recession. That was true with Hurricane Katrina, as it will be with other climate disasters, and that is true with HIV, as it will be with other infectious diseases like Mpox. In the context of structural inequities, disasters did make disparities worse, and the COVID pandemic was really striking in just how inequitable it was. This is a Washington Post figure on trends in unemployment, during prior recessions for people who are high income in green and lower income in purple. And you can see that people who are lower income have been disproportionately affected in past recessions, but nothing like during the COVID pandemic. When 50 million people lost work, it was really concentrated among the lowest income households that were most dependent on their paychecks. I mean, many people were living paycheck to paycheck and could not afford to have enough food to eat or housing to security without their paychecks. We similarly saw that in the context of structural inequities, disasters made health disparities worse, and particularly with COVID-19. Mary Bassett and colleagues in PLOS Medicine did really seminal work highlighting the importance of looking at age group specific disparities, because white populations are so much older in the United States than Black and Latino, Latina, and Latinx populations, that it is really important to look at comparable ages. And what we see with comparable ages is that really Native American people, Hispanic people, and Black people, these top lines have been disproportionately affected throughout the pandemic, especially in surges. These are deaths over time. And this is compared to white people in pink and Asian people in blue. We see that disparities have continued in the most recent period. So this is from January to October of 2022, the death rates for people aged 50 to 64, for people who are Native American, Native Hawaiian, Hispanic, Black, white, and Asian. So in orange is the most recent data, and then in red are the total deaths. And you can see that we still continue to see very large disparities, with more than twice as many Native American people dying per population relative to white people. So our rapid response approach was to develop the COVID-19 US state policy database. We knew that it was an important time to come together to respond to the pandemic. And coming together as a spirit we can still bring to public health and economic hardship and the challenges we continue to face with COVID and its ramifications and more enduring challenges and novel challenges. And so in the spirit of really wanting to facilitate widespread research, we made immediately publicly available the dates that states change policies like physical distancing policies and eviction policies. And then thanks to our students, we had my colleague David Jones reached out to students, and overnight we had 30 students volunteer to help us build this database, and we ended up building a database with more than 200 policies, tracking the dates when states changed those policies so that researchers could look at what happened before and after policies were changed compared to over time in states that didn't change policies. This is an example of what the data look like. We've tried to make it very easy for people to download and merge with their own data sets. And so here we provide the state, and in the downloadable file, we also provide the FIPS code. And then you can see the date that policies were changed. For instance, these are face mask policies since June 2021. So I'll give 4 brief examples of the analyses that came from this data set and a more detailed example. So the first more high-level example is a study on state face mask policies and reduced spread of COVID-19. So fortunately, our database was able to meet the objective of facilitating rapid response research, and other researchers used the data to conduct this study, merging the CUSP policy data with Johns Hopkins data on COVID cases and deaths. And you can see that after states implemented face mask policies, there was this immediate reduction in COVID cases and case rates, and then that there was an increasing reduction over time as for each case averted several other cases. This was a study led by John Jay at the Boston University School of Public Health, looking at physical distancing over time among people who were higher income and lower income, and how that interacted with stay-at-home orders, and really finding that people were starting to stay home even before the stay-at-home orders, and that people who were lowest income had actually been staying home most before, but were least able to change to stay home more during the pandemic, relative to people who were higher income, who were least likely to be at home prior to the pandemic, and then were most likely to be at home afterward. This is a study that I led in collaboration with colleagues, and we looked at unemployment insurance implementation and food insufficiency over time. We knew that unemployment insurance expansion at the federal level was very important because state unemployment insurance systems cover just about a quarter of people who lose their work. And of course, we saw that low-income people who were least able to withstand losing their paycheck were most likely to lose work. So federal expansion of unemployment insurance expanded it to include more people and for a longer duration and with a larger amount. During the CARES Act period, there was a $600 weekly supplement that later went to $300 in subsequent bills. And here what we did is we found that when people did receive unemployment insurance, that there was this immediate reduction in food insufficiency, and that this effect declined over time as the CARES Act did ultimately expire in July 2020. But fortunately, Congress was able to implement further stimulus bills, expanding unemployment insurance again and resuming the federal supplement. Most recently, we've done work on paid sick leave, documenting the percent of people who are missing work without paid leave during the pandemic in yellow relative to prior to the pandemic. So you can see that there are large increases in the proportion of people missing work without paid sick leave, and there are disparities where more women are missing work, more people with children are missing work, more people who are Black and Hispanic are missing work. more people who are self-employed are missing work, and especially more people who are low income are missing work without any coverage from paid sick leave. And again, when people live paycheck to paycheck, missing their paycheck due to illness, especially when illness becomes more frequent due to both COVID and the triple-demic, that is more of an effect on their health. And then we also did some work on minimum wage and food insufficiency, and finding that higher minimum wages were protective against food insufficiency as well. This is a more in-depth study led by Kate Leifheit on eviction freezes and their association with cases and deaths. And we saw just huge increases in housing instability and not being caught up on rent during the pandemic, and very large racial disparities. And we especially saw this effect among households with children. So the study design was states that ever instituted a moratorium. The study entry was when the moratorium was first effective, and then the study exit was when the moratorium, the CDC moratorium went into effect, or the state implemented a second moratorium. We conducted an event study that the exposure was the time since the moratorium was lifted. The outcomes were COVID-19 cases and deaths, and the covariates were testing rates and public health interventions. And we had fixed effects for time and state. Here you can see the states that are in light purple had eviction moratoriums they maintained throughout the study period. And here in dark purple, these are states that had eviction moratoriums and they lifted them during the study period, while states in gray never implemented eviction moratoriums. And here you can see that the median stop date of eviction moratoriums when these were lifted was in May 31st of 2020, starting in April, and then an increasing number of states lifting those moratoriums. When states lifted moratoriums, we found that that was associated with an increase in the incidence rate ratio of COVID-19, and incidence was 2.1 times higher. And mortality increased even more so. We found that lifting moratoriums was associated with 5.4 times higher mortality. We estimate that this would be associated with 433,700 excess cases and 10,700 excess deaths. Unfortunately, this study was able to help inform the CDC federal eviction moratorium that then was in place until August of 2021. And I will say that, there was some good news that came out of the policy world and the policy response. And coming back to the beginning and, thinking about how policies can exacerbate or counteract disparities in our structurally inequitable context, we saw that the economic policy response really resulted in an unprecedented decline in poverty, and that families were able to stay in their homes, that families were able to have enough to eat, thanks to these economic response policies, and in a way that they hadn't during prior crises like the recession in 2008. I also will say that all of these policies have expired while many of the challenges of COVID continue, such as increased rates of missing work due to illness, always the threat of another harmful surge or multiple surges due to new variants, and inflation, as well as new complications like long COVID. And we haven't seen sustained policies to help people maintain food and housing insecurity. Maintain food and housing security in this period. Also say that there's some bad news, that there were places where we could have had more evidence-based policies, more equity-oriented policies that would have saved lives. This chart depicts the death rate in high-income countries, the G7 countries, during the period from September 12th, 2021 to September 10th, 2022, really the period of the Delta and Omicron surges here in this first part of the year. And 350,000 people died in 7 months during that period in the United States. And That was more than double the death rate in other countries on average. All of these other countries we saw either had a mask mandate or high levels of mask wearing in Japan. We also saw responses like holding 24/7 booster clinics as the Omicron variant arrived in other countries. We didn't see a similar call to action and action in terms of supplying people with vaccinations and boosters that were easy to obtain when these variants hit the United States. And so one of the most important lessons we can learn is that if we do have another variant, like the Delta or Omicron BA.1 variant, that we can do better. We don't want this to continue happening. I think a lot of the work that we have remaining to do is to improve our vaccination coverage and equity. I think that's really imperiled by ending the public health emergency and making it harder for people to access vaccines and treatments if they don't have health insurance. So some conclusions from our work during this period: the evidence on vaccines, masks, tests and isolation, and ventilation and treatments is clear, but the implementation was in a context of inequitable power and politics. And this is a context that we affect. And so, I think it's very important for each of us to speak to the evidence, to speak to the importance of acting on the evidence, to speak to the importance of equity, and coming together to protect one another. It doesn't need to be an always or a never kind of policy implementation, but smart policy implementation can help us achieve a healthier middle ground so that we don't end up with so many more excess deaths than we need. Hundreds of thousands of lives lost that we might have prevented. Each of us has the power to contribute to a healthier and more equitable society. This is through research informing immediate and longer term policy responses. This is in terms of speaking to the evidence. And this is in terms of prioritizing society, not just ourselves, not just our children and their schools, but really prioritizing society, and especially those most affected by structural inequities, and thinking about how can we come together to support one another, and especially the most marginalized populations. I am so grateful to our team. These are the faculty members and main staff who contributed to the policy database, and in addition to 30 student volunteers. I'm so grateful to the CTSI for believing in our project and helping us get off the ground. We wouldn't have been able to do it without the funding from the CTSI and their rapid response turnaround, and their sharing that spirit of the importance of coming together to help one another through the pandemic. So I hope that's a spirit we can all continue going forward. Thank you for listening to this presentation, and thank you again to the CTSI for the opportunity.